So hello and welcome. Good afternoon, good evening, or good morning to friends from Asia, especially those joining us from Seoul, Tokyo, Taipei, Hong Kong, Hangzhou, Hanoi, Singapore, and elsewhere. I'm Karen Eggleston, Director of the Stanford Asia Health Policy Program, and I'm delighted to welcome you to this webinar on assessing the net value of medical spending, part of our Colloquium series on aligning incentives for better health and more resilient health systems in Asia. We are excited to welcome three experts discussing cutting-edge methods today on this topic. In alphabetical order, our speakers are first David Cutler, who is the Otto Eckstein Professor of Applied Economics in the Department of Economics at Harvard University, with secondary appointments at the Kennedy School of Government and the School of Public Health. He was Associate Dean of the Faculty of Arts and Sciences for Social Sciences from 2003 to 2008. Professor Cutler has served on the Council of Economic Advisors and the National Economic Council and has advised several presidential campaigns. He is a research associate at the National Bureau of Economic Research, a member of the Institute of Medicine, and he has held positions with the National Institutes of Health and the National Academy of Sciences. Dr. Abe Dunn is the Assistant Chief Economist at the Bureau of Economic Analysis. His work is focused on the production and development of a new satellite account for healthcare and on evaluating and using alternative data sources for measurement purposes. The healthcare satellite account uses billions of medical care claims from public and private sources to improve measurement for the US healthcare sector, which allows researchers to analyze spending trends by medical condition. Dr. Dunn has published research on a range of topics, including the cost and quality of medical care treatments. He received his PhD from the University of Texas at Austin. Marcia Weaver is professor at the University of Washington, and she earned a PhD in economics at the University of Chicago and specializes in cost effectiveness analysis with over 80 peer-reviewed publications in the field. At the Institute for Health Metrics and Evaluation, she leads the research team on cost effectiveness analyses of interventions to reduce the burden of disease. Professor Weaver has extensive experience with infectious disease research, evaluating clinical training programs, and advising ministries of health from Nigeria and Uganda to Indonesia and Thailand and other parts of the world. So thank you all for sharing your insights with us today. David, over to you.
Well, so first, Karen, thank you so much for inviting me and for organizing this. The pandemic has made many aspects of life worse, but one of the ones it's made better is the ability to communicate without physically traveling. So I appreciate the invitation. I'm delighted to be with you. What I'm going to do is to talk a little bit about an effort that I and a number of others have been engaged in to put together what are called satellite accounts for the medical care sector. And a satellite account is kind of what the sort of astronomy would lead you to think, which is it's an account that sort of orbits around the official national income and product accounts. And I'm just going to arrange my screen here so that I get what I want. So give me just 1 second here so that I can make sure I've got everything here. And so it shows things about the medical sector that you wouldn't otherwise get to know about. So let me tell you a little bit about what I'm doing. I should say there are 6 people who are involved in this presentation, and they're all here, and there are many, many more who have contributed to it. So let me start off a little bit with just a publication sort of announcement, if you want to see it, which is we developed a satellite health account for the US, and it was just recently published, as in February of 2022, so very recently published in the American Economic Review. And so for people who want a lot of details, I'm delighted to send it to you, and of course to talk to people and so on. So I'm happy to share it to you. But the other reason why I wanted to show this is this quote at the beginning from Simon Kuznets, the founder of National Income Accounts, who wrote that the welfare of a nation can scarcely be inferred from a measure of national income. And of course, he was put together national income and product accounts. So what he was doing was sort of noting that they weren't a complete guide to welfare. And amongst the items that he pointed out made it not a complete guide to welfare is that it didn't really deal with health very well. Because health itself, the output health, is not a monetary thing. And so there's sort of an issue about how one deals with it. And a lot of the interesting issues since then have been about how do you deal with that. And so we've been spurred in this research partly by Simon Kuznets, and also, quite frankly, partly because of Abe and his colleagues at the Bureau of Economic Analysis, who have said, look, we want to do better on health accounting. Can you people in the research community try and help us do better on health accounting, because we don't want to be in a situation where we're not really measuring what it is we want to measure. And so based partly on a challenge from like that, we sort of decided that we really needed to know a little bit more. So let me tell you what it is that we did. Let me start off with the basic fact, which is that in the US, as in most other countries, the productivity in the healthcare system is generally very low. So if you look here, average productivity in the US is about 1.5% or so. And healthcare is a very low productivity growth rate over time. That's too not particularly well measured. And there have been the sort of issues associated with the mismeasurement of productivity in healthcare have been around for a number of years. The earliest publication here that I show you is from the mid-1990s. There have been various other reports, National Research Council reports. There was a book that Ernie Burnt and I edited. There are a number of reports that have sort of pointed out some of the insufficiencies with the current national income accounts. And really there are two ways in which they don't get things right. And so the challenge of developing a satellite account is to address those two ways. The first way, and the one that people most think about and is super important, is the measurement of output. So when you come back here, the output in the productivity growth tends to be things like the number of hospital days, the number of physician visits, the number of scans and tests. And that's not really what we want. Like, we don't go to the doctor because we want to get more scans, more visits, more things poked and prodded into us and at us. We go because we want to improve our health. And so the thing that's missing that all these things point out is that we don't have a good measure of health. So if we spend more, but our health improves because we're spending more, that would be a productivity improvement, but you may not measure that by the number of hospital days or the number of tests that I receive and so on. So that's the first issue, is that the physical quantity of medical care services I receive is a very poor guide to the health outcomes, very big one. And so that's the first issue, which means you're going to have to measure health outcomes directly. The second issue is slightly more subtle, but it's really important, which is that traditional national income accounts divide industries by who's providing the service. So an industry is physician services, and an industry is hospital services, and an industry is pharmaceuticals, and so on. And the analogy is food services. That is, an industry is chicken, and an industry is beef, and an industry is fish, and an industry is cereals, and an industry is bananas, and so on. And I do care about those in the food circumstance. That is, I care a lot about, am I eating bananas or am I eating cereal? In the medical care context, it's much, I probably care much less. In fact, I almost certainly care much less. That is, to a first approximation, I don't care if what the doctor does is give me a pill or wave a wand over me or operate on me, although there's a short-term pain from that. What I really care about is, did I get better? And so what that means is that our traditional industry breakdown is not very helpful here, because when you're trying to break down things by pills and surgeries and doctor visits, you're going to get it wrong in the following sort of sense. Let's say that I used to hospitalize people who had a particular condition, let's say heart disease, and now I can give them a pill. And so they take the pill instead of the surgery. Let's say the pill was always around and the surgery was always around. It's just I learned the pill is better, so now I give more people the pill. In each industry, that is in the surgery industry and the pill industry, there's no productivity improvement, because one pill does the same output, it treats one person. One surgery does the same output, it treats one person. And so there's literally zero productivity growth. But in fact, if the pill is cheaper than the surgery, there's actually enormous productivity growth, because for lower spending, I get to be healthier. And so the issue here is that I don't want to think about industries as being pharmaceuticals and doctors and hospitals. I want to think about industries as being diseases for which I want treatment. So we're going to reconceptualize, and not just we, but Abe has done this in other work, and Marcia has done this in other work. We are going to conceptualize an industry as a disease that a person has for which they will want treatment. A disease is heart disease, a disease is lung cancer, a disease is diabetes, a disease is chronic back pain. And then within that disease, what I'm going to say in my research is I don't care how I'm treated. I don't care at all. All I want to know is how much money did I spend and did I get better? And so when I conceptualize health accounts, what I'm going to do is I'm going to say, here's a particular disease. Did I get treated and did I get better? Now, of course, I may have multiple diseases and I may care about the treatment of me as a whole. Because I do want to know something about by disease. And I think are we doing much better for people with heart disease in comparison to people with musculoskeletal disorders and so on? So I do care about a lot of those. So with that in mind, let me then, we did a lot of empirical work, which I'm only going to summarize, and thankfully I can direct you to the paper. But I want to give you first the conceptual underpinnings, which are that we have two fundamental inputs to a national health account. There are the things that affect my health, medical care, the behaviors that I engage in, things about the environment and genetics. And then there are certain outcomes. And the outcomes, there are going to be two principal outcomes here. One is health itself. And I'm going to value health in dollars, the way that we as economists value health in dollars by saying, you know, what are people willing to pay to extend their life? There's a second measure of outputs, which is how much more can I earn because I'm healthy? That is health as an investment. How much more over my lifetime will I earn? Because the accounts I'm putting together are for the elderly population, which in the US is not particularly working, elderly being over 65. I'm not going to deal with that particularly here, but it is floating around in the background. So the first thing I'm going to do is I'm going to measure the inputs, medical care, behavioral risk factors, so on. I'm going to measure the outputs, health. I'm then going to bring them down and I'm going to do an aggregate analysis, which is I'm going to say what was the overall change in lifetime medical spending and what was the overall change in quality adjusted life expectancy. So what is my overall change in the input of the medical sector? That is how much do I spend, and what is the overall change in the output? That is what is my life expectancy. Now, of course, not all of that quality adjusted life expectancy is due to medical care. So I'm actually got a method in the background to parse that out. The method more or less that I'm going to use is to say that the prevalence of disease is not influenced by medical care, like whether I have, you know, back pain is not influenced by medical care, but the outcomes of that, that is what is my functional status after that, is determined by medical care. So that's a rough guide to how I do this here. There's of course much more detail. The most important detail is that some factors are explicitly risk factors, like high blood pressure, high cholesterol, and so on. And so some diseases are allowed to affect the prevalence of other diseases. But for example, if high blood pressure increases because people are more obese, which is what has happened in the US, I'm not going to call the increase in obesity a result of medical care. And I'm going to back out all the stuff in terms of health decrement, which is due to increased obesity, and all the benefits, which are due to reduced smoking. And I'm going to say those are outside of the medical system. What is inside the medical system is how well I do once I'm treated for those conditions, whether it's a risk factor like hypertension or a disease like heart disease or cancer. So I'm going to measure those in aggregate, and I'm going to parcel out the part which is due to behavioral risk factors from other stuff. This is not exact. This is not an exact science. So there's a sort of an analytic step in here that you kind of have to get over. One of the things that have these analytic steps, they do all sorts of hedonic adjustments and stuff like that. It's not that we avoid them. It's just that we make sure that they're grounded in good theory. Okay, then I then get to decompose things by conditions down here. So I get to take all these conditions. I've got 80 different conditions, and I'm going to sort of look and I'm going to see what was the increase in spending on each one, what was the improvement in health or reduction in health, and then I can compare them. So I can say how many years of quality adjusted life expectancy did I get in each disease? How much did I spend over time treating that disease? I'm going to value the quality adjusted life expectancy in dollars using standard valuation techniques. When I say standard valuation techniques, the numbers that are most commonly used in the US are that a year of life in good health is worth $100,000. And I'm going to experiment with a year of life being worth in good health being worth 50,000 and a year of life being worth 200,000. That's roughly the range that researchers in the US will tend to use. And so I can compare the health change in dollars to the spending change in dollars, and I can estimate the net value of medical care spending over time. Okay, so that's the methodology that I'm going to use. I'm just going to very briefly tell you about the data. The data needs here are not trivial, but the reason why I'll be quick on it is because the data systems differ in different countries, so I'll need to be a little bit quick. But I do have data on the elderly population in the US, essentially the whole elderly population, although I only have some information for parts of it, from 1999 to 2012. There are now more recent data. This partly reflects how long it took to actually do the analysis, I'm sad to say. And I know total spending for people over that. And then I do a bunch of adjustments, which I'm not going to deal with here, but just to make it sort of population representative. Medical spending has increased over time in the US. This is spending on the elderly population over time. It has increased at a decreasing rate. This is not a fluke in the US. There's a fair amount of work put into why is it that the growth rate of medical care spending has slowed, and part of it is because the medical system did a good job treating people and preventing disease, so that the treatment was here and the disease prevention is over here on the right. So that's not a fluke, but that increase in spending is of course indicative of, if you're not measuring health outcomes, what's going to look like a low productivity growth rate. And so that's something you're going to deal with. At the same time, mortality rates in the elderly population have fallen. You can see here the reduction in mortality, age-adjusted mortality in the elderly population is really quite rapid. So what I do here is we just, again, very briefly, we take 285 underlying conditions that are put out by the US government. We group them into 80 conditions. And then with those 80 conditions, we generally roll them up. There's a bunch of stuff going on in the background about what is the true disease prevalence, which is different than the prevalence that doctors write down on sheets of paper when submitting for billing purposes. So we deal with a bunch of that. And then those 80 conditions, most of them are what we call direct conditions, like heart disease and cancer. Some are risk factors like high blood pressure and high cholesterol, and some are screening. Those are really important to get at, but they're difficult to sort of, because of just numbers of people, difficult to get at wholly, but we do make an attempt to get at them. Okay, so we do all that work in the background. So we measure the health outcomes for people with each condition. We attribute the part, which is a good part of that to medical care services. We get, and so to medical care, and so we get the change in the quality adjusted life expectancy associated with each condition. I didn't show you here, but quality of life is actually pretty constant in the US. So even as mortality is going down at any age, people are reporting roughly the same health over time. And then we compare that. We compare for each condition. These are the 30 rolled up conditions. We compare for each condition the improvement in health, to the extent there is one, to the increase in lifetime medical spending. Okay, and so we know that because we know how much more was spent per year on each person with the disease, and we know how long they'll live. So we say, okay, if they've spent that much each year, how much more would they spend over their lifetime? So what you're seeing here is the net version of that. So the blue line is the health gain. If it's to the right on the figure, that means that it's actually a positive health gain valued in dollars. And if it's to the left on the figure, that means there was actually a greater, that actually means that people with that condition had suffered greater quality of life decrements or greater mortality over time, and that's associated with a reduction in health. Most of these numbers, most of these blue bars are to the right of the line, which means that health improved for people with most conditions. Remember, I've taken out the impact of obesity, which is a huge issue in the US here. So I've taken out a big part of that through obesity, and I'm looking just at people with the condition. The second part of what you see here, these sort of crosshatch, that's the increase in lifetime spending. So that's using a 0% discount rate. That's the increase in lifetime spending on that condition. And if it's moving to the left, that means lifetime spending went up, so it subtracts from the value. And if it's moving to the right, that means that lifetime spending fell and it's adding to the value. The red dot is the net. So the red dot is the blue line minus the increase in spending. Okay, so the red dots are telling you about the productivity of each disease. And now you can look at the different diseases. So you see the heart diseases up front, then you see cancers, then you see mental health, and so on all the way down to the end. What jumps out about this are a couple of things, and I've sort of listed the conclusions here. The first one is on net, more things are to the right than they are to the left. That is, on net, the medical care system has been fairly productive. The benefits on net have been over $100,000 per person, roughly a 1.5% per year productivity increase. So that's our first finding, is that is actually positive, nowhere near as high as, for example, the computer industry or other kind of things, but actually not terribly low either. The second thing we find is that there's a lot of heterogeneity in that. The conditions for which we in the US have achieved the highest benefits are predominantly heart disease. Ischemic heart disease, sort of problems with the artery supplying blood to the heart, congestive heart failure, which is a chronic weakening of the heart muscle, and other kinds of heart diseases. All of them have seen large improvements in productivity, huge health gains, some increase in spending, but not that big. You also see scattered other benefits for things like colorectal cancer and lung cancer a bit, although the spending look like they've been actually very poor. Infectious diseases, the US has done worse on. And one thing that's particularly worth noting is the injuries. The US, as I'm sure many of you will know, has a huge opioid problem. We spend a lot of money on opioids, and it's not only not improving our health, but it's actually harming our health by getting people addicted to opioids and dying of opioid abuse. And you're seeing some of that here, and some of these things down around here, which are treatment of musculoskeletal conditions where the costs have increased enormously, and in some cases, the benefits have actually been negative. So you're sort of seeing notable failures in musculoskeletal conditions, also somewhat interestingly in mental health conditions, where we have a lot of effective treatment, but when you look at mental health conditions in the US, you still don't see much improvement over time. And that's consistent with the fact that many more people are on medications in the US, but that overall population mental health has not changed, which either means that way more people would have been hospitalized or would have had those conditions, or just that the conditions that people have are not being fully resolved. Okay, so that's a little bit at the US. I spent a little more time talking about the virtue of such accounts and how they would be conducted, because I think I would love to see them done for multiple countries. I'd love to be able to compare the US to other countries. I just love to see people sort of use this to try and make sense of the medical care system. And so let me just stop at that point, and thank you again for having me and tolerating me.
Thank you very much. Dr. Dunn, over to you.
Okay, thank you, and thank you for inviting me. I'm really excited to be here. I mean, well, how David ended that, I'd be really excited to get something like this, for the U.S. accounts, officially up there. I think, let's see, can we see? Which is something I think we're all working toward. Can you see that all right?
Yes.
So great. So today I'm going to be presenting our paper called "Are Medical Prices Still Declining?" where we're going to be looking at quality adjusted prices using information from cost effectiveness studies. And this is joint work with Ann Hall and Seydou Douda. And of course, the usual disclaimer applies that these are my views and not necessarily those of the Bureau of Economic Analysis. So the title of this talk is just a spin-off of a well-known paper by David and his colleagues, where they asked the question, are medical prices declining? And they asked this for the case of heart attack treatments, where they noticed the nominal price of treatment was rising, that the quality of those treatments was also rising, as reflected in improved survival rates. And they put these estimates together, and they found that to form a quality adjusted price index, and they found that quality adjusted prices were in fact falling. And now if what they found for heart attacks is true of the healthcare sector more broadly, this has really important implications for output and productivity for that sector, but really the whole economy, as David showed in his presentation, where it was a more comprehensive analysis. And I think this is even more important today than it was a couple of decades ago, as we've seen healthcare spending grow as a share of GDP from 13% to 18%. Life expectancy has grown by nearly 2 years over this period, and there's likely a connection there. A lot of the spending growth is driven by new technologies driving spending higher, but also contributing at least somewhat to that improvement in life expectancy. Now, all of these improvements in medical technology and in treatments is currently not reflected in official measures of inflation. And in fact, a couple of papers that have reviewed where the biases may be in price indices concluded that nearly half of the potential bias likely to be due to the healthcare sector. And you might wonder, well, why hasn't this been solved? And the reason is it's a really challenging problem. Kind of the typical tools that economists use to quality adjust that rely on revealed preferences don't work well in the healthcare sector because of things like moral hazard and principal agent problems or information imperfections. One possibility is to use population health measures, but the challenge there is separating out population health, separating out the contribution of medical care from other factors like smoking and obesity. I think actually I think David's paper does a nice job of this, tackling this problem, but I think it is a tricky issue, and it's important to kind of look at other ways of doing this as well, which is what we're doing here. Then finally, you could think about doing this one condition at a time, but the challenge there is that, the issues involved in measuring each condition are distinct, which would be hard to kind of do this in a really comprehensive way. So the approach we take in this paper is we're going to try to leverage all of that knowledge in the medical care literature and use information from cost effectiveness studies that have all the key pieces of information that are needed to quality adjust prices from new innovations. And we're not just going to look at cost effectiveness study from one study. We're going to leverage a database of over 8,000 cost effectiveness studies that have this information to form these quality adjusted price indices. And we find that for the typical innovation, we see quality adjusted price declining by about 20%. But for many innovations, the price decline is actually even larger than this. So with just looking at innovations alone, you can't say much about aggregate inflation because you're not getting new treatments every single year. So to bring this into an aggregate measure of quality adjusted price index, we have to combine it with other information on the cost of disease treatment over time, but also have information about the diffusion rate of new technologies. And we do this, we come up with a kind of a rough estimate of the quality adjusted price change for the whole healthcare sector, which we find to be about 1.3. We find a decline of about 1.3% relative to economy-wide inflation. And this is our central estimate. We do find that this estimate is somewhat sensitive to the assumptions we make, such as the diffusion rate of new technologies, but it's especially sensitive to the value we place on a statistical life year. Like David's assumption in his paper, we also put our central value at $100,000, and that's where we get this 1.3% price decline. But we do get different estimates if we look at either lower or higher values, which I'll talk about at the end. So that's kind of a quick overview of this paper, and I'll kind of step into some of the details. Prior to really the three papers that are presented today, at least that I'm aware of, a lot of the work in this area has been focused on individual studies, which makes it hard to kind of scale it and make it more comprehensive for the whole healthcare sector. The approach that we're taking in this paper is a bit different. Rather than focusing on the population health, we're going to leverage this large database of cost effectiveness studies. Specifically, it's called the Cost Effectiveness Analysis Registry, or CER database from the Tufts Medical Center. The cut of the data that we are using has over 8,000 of these studies, where the bulk of these studies is from the past couple of decades. But this database really aims to be comprehensive, and they try to get every cost effectiveness study in the literature, covering a wide range of different conditions, and covering a wide range of different types of interventions, from pharmaceuticals to procedures to devices. And for each study, they have two readers go through and extract over 40 variables from each of these studies. And critically, for this study, they pull four key pieces of information. They pull information on the price of the innovative treatment that's being studied. And this price includes both out-of-pocket costs and also the cost paid by the insurer. They also have a price of a standard of care treatment. That is a treatment you might receive if that innovation didn't exist. They have information on the quality adjusted life year from that treatment, or quality from that treatment, the innovative treatment, where one quality is 1 year of life in perfect health, trying to account for morbidity and mortality. And they also have that same quality measure for the standard of care treatment. And with these pieces of information, you can afford a quality adjusted price index for moving from that standard of care treatment to that innovation. So before kind of stepping into how that index is formed, just give some descriptive statistics of what we see in the data. Kind of the first 4 rows here are the key elements that we use and showing the distribution of each of those, where you see some things you expect. The qualities from the innovation, both the mean and the median, are a bit higher than the qualities you get from the standard of care treatment. And similarly, the price of the innovation, both at the mean and median, is a bit higher than the standard of care treatment. The question is, well, how do we turn this into a meaningful price index? And it turns out that it's actually comes out directly from how you might think about calculating the net benefit from treatment, which is pretty straightforward. To calculate the net benefit from a treatment, you would take you basically take the change in health and qualities, the health from the innovative treatment minus the health from the standard treatment, and you multiply that by the value of a statistical life year, say $100,000. This is what health economists typically do. Thanks to David, and then we're going to subtract off the change in the cost of treatment of the innovation relative to the standard treatment, and that brings us to the full net benefit. Just basically benefits minus costs, and we can see how this works for a well-known treatment. Sovaldi, which made headlines in 2014 because it could actually treat and cure, in many cases, hepatitis C, in cases where it couldn't be cured previously. And it made headlines for 2 reasons, both because it was extremely effective, but also because of its price tag, which was over $100,000. So what I'm going to do here is just kind of go through what this net benefit calculation looks like for this particular case. Assuming a value of a statistical life year of $100,000, you see that Sovaldi had a quality of 9.4, which was higher than the standard treatment at the time before Sovaldi, which was interferon, which had a quality of 8.28. But at the same time, the cost of Sovaldi was higher, over $100,000 relative to interferon. And you put that together, kind of the large benefits minus the $24,000 in additional cost, you get a net benefit of $87,000. And it turns out you can use this net benefit to plug that directly into standard utility-based price indices. There's either a Laspers version of this or a Posh version of this. They both have similar kinds of intuition, so I'll just focus on the Laspers index. Where if the net benefit of this new innovation is 0, so suppose there's no actual benefit to the treatment, then this index value is just going to be 1, indicating no change for individuals in terms of the cost of treatment over time. If the net benefit is positive, as it was for Sovaldi, then this index is going to be below 1, indicating a quality adjusted price decline. And some other intuition you can get for how this index is formed is you can actually plug in some of the values for net benefit, and you come down to this alternative index formula, which is just basically broken into 2 components. One component is the unadjusted cost of treatment, the first component, like how much more does it cost to be treated for Sovaldi relative to interferon? And the second component is just how much more quality are you getting from Sovaldi relative to interferon? And then that gives you the net benefit. The same, just intuition, 2 different ways. Now we can bring those numbers I showed you for Sovaldi to these 2 indices, and these are the values that we get. The Laspers index, we actually end up with an index value of a negative index value of 0.09, indicating a price change of 109% decline. Actually, it's so innovative that you'd actually have to pay someone to take that previous technology treatment. A Posh index is a little bit different. It's bounded by 0, so the price change is smaller. The price change is just the decline of 45%. So this one example kind of gives you the intuition for how we deal with each observation in this data. Then we go ahead and calculate this quality adjusted price decline for all of the observations in this data. And we actually have 10,000, over 10,000 observations, because oftentimes studies have more than one comparison per cost effectiveness study. And this shows you the distribution that we find for both the Laspers index and the Posh index. And we show this for 3 different values of a statistical life year, 50, 100, and $150,000. So for example, the central estimate of the Laspers index at the median is showing an 18% price decline. But what's really kind of jumps out is the mean shows a very large price decline of over 100%. And what this is coming from is some technologies are actually, cost relatively little and improve quality, by a lot. And that leads to very large quality adjusted price changes. And things, sometimes you look in the data and there's things like you wouldn't really expect, like, colon cancer screenings that, are actually diffusing in the US, but turn out to be very cost effective for certain age groups. And similarly, another one is HPV vaccines to help prevent cervical cancer. Again, it's a low cost technology that has potentially a large benefit. So this alone tells you kind of the quality adjusted change from innovations, but another question is, okay, well, how do we bring this into kind of an aggregate estimate for the healthcare sector? And to do that, we need to take, an additional step. And here we're going to go back to that Laspers price index, but instead of thinking of the standard treatment to the innovative treatment, we're going to think about changes in the cost over time from one period to the next. And what we show in our paper is you can actually kind of go from this formula and approximate it using this alternative formula, the next formula down here. And it has basically three components. The first component, ST over ST minus 1, is just the unadjusted cost of treatment. Say, how much does it cost to treat diabetes today relative to the previous period? And this second component is, how much, what is the quality adjusted cost of a new treatment? Say it's going from, for example, from interferon to Sovaldi. And then the last piece that's needed is we need to know how much to weight new innovations versus, just unadjusted index. And for that, we need this delta W, which is going to be the diffusion rate of new technologies. It tells us how much to weight each of these indices. And what we need for that is we have to go to empirical counterparts for each of these things. So for the unadjusted price index, so just looking at the cost of treating diseases over time, we turn to an experimental account from the BEA, which is called the healthcare satellite account, that tracks exactly this information, the cost of treating diseases over time. The second piece of information draws upon the SEER database, where we can use those estimates I just showed you, look at central values of the quality adjusted price changes we see in that data. And then finally, the last piece we need is a diffusion rate of new technologies, which is a little harder to find that data, but we look for a number of proxies that we think indicate how quickly technology is changing. We look at claims data and prescription drugs to see how quickly new molecules are adopted over time. We also look at claims data, look at how quickly new procedures are adopted over time to give us a sense of how quickly technologies are adopted. And finally, we look at hospital quality data to see how quickly hospitals adopt new quality practices over time. And we think none of these indices is perfect, but they are roughly and not too far from each other. And we average these three, and the average kind of technology change is around 2.8. So that's the number we use for our central estimate, but we report a kind of a range in our paper. And these are the estimates we come up with for the quality adjusted price change. Our central estimate, using a value of a statistical life year, is $100,000. We find a 1.3% price decline on an annual basis. If we set that value of statistical life year to be a bit higher, say $150,000, we get much higher price declines of 3%. And if that value was around $50,000, we'd actually get a price increase of 0.67, which is roughly what our official measure of inflation is currently. So that's kind of the last main slide there. The first two bullet points I just kind of talked about, and really the main the main thing that I think we're adding here is I think that these cost effectiveness studies do provide a distinct tool to try to look at and try to estimate quality adjusted prices. It relies on very different assumptions from the kind of work David has done, but at the same time comes to very similar conclusions. So thank you.
Great, thank you so much. And Dr. Weaver, over to you.
So I'll begin by acknowledging that I'm presenting from the traditional home of the Coast Salish peoples, who are the original caretakers of this land and continue to live here today. I'd also like to acknowledge my co-authors, without whom this work really would not have been possible. So our goal is to estimate how much we in the United States spend per unit of health gained by cause at the population level, which we call spending effectiveness. It's similar to a cost effectiveness analysis of individual products or services, where lower spending per health benefit is considered more effective. We're in good company, as you've seen. Previous researchers have conducted research with patient-level data for specific causes, including myocardial infarction, depression, diabetes, congestive heart failure, and pneumonia. They've also conducted research with population-level data for multiple causes, including work looking at non-communicable diseases, spending and DALYs per person, or spending and DALYs per patient, and then Professor Cutler's research for the across all causes for ages 65 and older, looking at spending per increase in quality adjusted life expectancy. Research on this important topic has been limited by the absence of comprehensive data on all causes and all age groups. We now have data from the Global Burden of Diseases, Injury, and Risk Factor study that estimates DALYs by cause for every country, and from the Disease Expenditure study that estimates spending by cause for the United States. Importantly, the disease classifications were developed side by side so that we can match spending to health outcomes. We want to focus on the effects of medical care. So to do that, we want to control for changes in other factors over the same time period, such as population growth, changes in the age structure, and changes in cases per person. And we attribute changes in spending per case and DALYs per case to healthcare after we control for the other factors. So looking at the data, the GBD is a public good. Our 2019 results were published in a special issue of Lancet, and the results are available to you to use in your research through a visual data visualization at the Viz Hub at this link, and in spreadsheets or CSVs at the Global Health Data Exchange, GHDX, at this link. The metrics that we use are disability adjusted life years, DALYs, which are the sum of years of life lost, YLL, due to premature death, and years of life lived with disability, YLD, which is time spent sick or injured. So on the lower right, you can imagine a person's life where a child is born healthy, indicated in gray. They experience episodes of illness and recover, where the episodes are indicated as DALYs in orange. And then later in life, they develop a chronic condition and experience YLDs from that chronic condition until death. And then at death, we calculate the YLLs as the difference between the age of death and the standard life expectancy at death, at age of death. So, and then the disease expenditure data, the most recent version with results from 1996 to 2016 were published in Lancet and in the JAMA. Those data are also available in a data visualization and in the GHDX, and you can go to the IHME website for those links. Here are some descriptive statistics for the United States in 2016. So you see that we spent $802 million per 100,000 population, or about $829 per person. We had 30,225 DALYs, or just under a third of a DALY per person. 16,193 of those were YLLs, which accounted for 53.6% of total DALYs. And in the 7 causes that I've shown here, the majority of DALYs are from YLLs. The lowest is for stroke at 66.2% of DALYs were YLLs, and that's still above average. In the right column, you see that we measure cases with the best available measure in GBD. So for infectious diseases and for neoplasms or cancers, we measure cases by incidence. And for chronic conditions, we measure cases by prevalence. So for our decomposition analysis is a calculation. It's not a statistical analysis. So to introduce it, I want to show a two-factor case where we imagine only cases and DALYs per case. So we can write DALYs for age and sex group I, cause K, and time T, as cases times DALYs per case by just multiplying by the identity of cases over cases. So to look only at the change in DALYs attributable to the change in DALYs per case, we hold cases constant at their 1996 level. So in equation 2, you can see that cases is we use the same cases in 1996 in both terms, and then we subtract the difference in DALYs when we use the 1996 cases per DALYs per case and the 2016 DALYs per case. We could also do the equation, the calculation holding cases constant at their 2016 level. And in fact, we do it both ways and take the average of the two calculations. So in our study, we have 4 factors. So we multiply DALYs by 2 more identities, population over population, and population in age and sex group I divided by population in age and sex group I. And we rewrite DALYs in all 4 factors: population growth, share of age and sex group I in total population, number of cases for cause K in age and per population in age and sex group I, and then DALYs per case for cause K. We calculate the average marginal effect of changing one factor across all combinations of the other 3 factors, and we refer to the average marginal effect of changing DALYs per case as the change in DALYs per case. We call the, and for spending, we call it the change in spending per case. And then our spending effectiveness ratio for cause K is the sum of that change in DALYs per case for all 23 age groups for 2 sexes. And the new denominator is the change in DALYs per case across those same 46 age and sex categories. So this gives you some demonstration of what the decomposition results. The black dot is the total percentage change in spending on the left, DALYs on the right. And we see in dark green the increase in spending on the left from an increase in population. Light green is the change in the age structure of the US population towards more elderly. Dark blue is the change in the case rate, the cases per person. And we see decreases for lung cancer and increases for pancreatic cancer. And then in light blue, what we're most interested in is the change in DALYs in spending per case. And for 6 of these 7 causes, there's been an increase in spending per case, breast cancer being the exception. And then on the right, when we look at the change in DALYs per case, we see that there's been a decrease in DALYs per case for all 7 causes. Going forward, we're going to refer to a decrease in DALYs per case as an increase in DALYs averted per case. It's the same thing, but one stated in sort of positive terms. When we focus on 41 causes with high spending or high burden in 2016, we see that 13 causes had an increase in spending and a decrease in DALYs averted, which is not good. Breast cancer, which we saw before, has a decrease in spending and an increase in DALYs averted, which is good news. And then 27 causes have an increase in spending and an increase in DALYs averted. So looking at those 27 causes in more detail here, we see the change in DALYs averted per case along the horizontal axis on a log scale, and the change in spending per case in 2016 dollars in the vertical axis, also on a log scale. The green dots refer to show that spending per DALY averted, and all of the green ones are less than $100,000 per DALY averted, and it shows some of the same causes that that Professor Cutler showed, such as ischemic heart disease, stroke, colon and rectal cancer, diabetes. In the upper right corner in yellow is the result across all causes, and we have about $114,000 per DALY averted for the entire health sector over this time period. And then in the upper left, the maroon indicates causes where the result was more than $500,000 per DALY averted, which is a lot. And some of these, like low back and neck pain or anxiety disorders, are what we call non-fatal causes, where all of the burden is from YLD. And I'm not, at this point, we don't measure changes in YLD per case very well for all causes in GBD. So we don't know if these are particularly inefficient sectors of the economy, or inefficient diseases for which we have fairly inefficient treatments, or if we also have a problem with measurement, or both. So I also wanted to show that we apply these results to construct an outcome-adjusted healthcare price index. And our goal is to construct a price index with units and health outcomes that are consistent across time, rather than outputs such as hospital stays or prescription drugs, for many of the reasons that Professor Cutler and Abe have already talked about. So we adapted Cutler et al. And Dauda et al.'s quality-adjusted price index to the results of our decomposition analysis. And our reservation price index is the ratio of total spending on cause K in 2016, the total spending on cause K in 1996, plus the dollar value of the DALYs that were averted over that time period. So it's the change in DALYs averted per case, which is the same term as the denominator in our spending effectiveness ratio. And for the dollar value of healthcare, we used similar measures of either $100,000 or $150,000 per DALY averted from the value of statistical life literature. So these results show, first in the left column, the ratio of healthcare spending in 2016 to 1996 without any adjustment, and it's 1.76, which would indicate that healthcare prices increased 76% more than the economy overall. And it's consistent with both the current healthcare price indices and the popular belief that prices are growing more quickly in the healthcare sector than the rest of the economy. When we adjust for the additional DALYs that have been averted over time at $100,000 per DALY, the ratio is 1.04, which would suggest that prices in the healthcare sector are growing just 4% more than the economy overall. And when we value them at $150,000 per DALY averted, the ratio is 0.87, which would indicate that prices were increasing at a slower rate in the health sector than the economy overall. So there's an important discrepancy between the popular perception of the increase in prices in the health sector and these outcome-adjusted results, which I think merit future continued research. And the three things that I would want to work on, one is to have more evidence on changes in the severity of illness, which is the measure of YLD per case. And my colleagues in GBD are working on that, although that work has admittedly been a lower priority during the pandemic. I'd also like to conduct the analysis in a health-adjusted life year framework similar to Professor Cutler's and calculate YLL based on the risk of death in the United States rather than standard life expectancy, which is based on the lowest observed risk of death globally. And then finally, I'd like to be able to explore spending effectiveness across different time periods. The decomposition method that we used is nonlinear and can be sensitive to data fluctuations. So it will be important to distinguish data fluctuations from changes in trends in spending effectiveness. So thank you for your attention, and I'd be happy to provide more information in this session or by email.
Great. Thank you all so much. So time for a quick question to each of you for a minute. First, Dr. Cutler, could you share your views about applying these methods to other age groups and incorporating other human capital outcomes beyond quality adjusted life expectancy, like you mentioned, earnings potential, or even maybe educational attainment from, say, better treatment of mental health among young adults?
Yeah.
What do you think?
So one of the things that I'm working on now is actually extending it to other age groups. The restriction to the elderly is not because I thought it was the best or even the wisest, but because the data are best there in the US. But so we're using somewhat less good data, but bringing it all together for the non-elderly. And then we'll be able to compare across age groups, which I think will be really important, because in the US, we've had disparate trends, different trends in mortality, quality of life, length of life by medical spending by age groups for us to look at.
Great. Well, thank you. Dr. Dunn, you are unique among us today for being a US government employee directly implementing these methods in your official capacity. Could you share with us insights from the Bureau perspective, especially for counterparts working in government agencies? We have some from Korea and so on. How do you make the case for better research on measuring productivity of the health sector? And how do you view trade-offs between your own work in-house versus collaborating with academia, contracting out pieces of the work?
Well, I think we're working together in BEA, but also, we're looking at the work of people like Marcia and David, and that they're helping us build a case for why this is so important. I think, we actually need to convince people, why this is important. It's not enough to say, look, clearly health is important. There's been lots of papers out there. We need to actually show how it might be constructed and build those estimates. And then even when we do that, I think, this is a very tough topic. I think it's going to be important that we not just show one estimate, that we show kind of a range of estimates and methods for some time until this is settled. I think, it's a very challenging problem. So I think that's maybe one approach to this, is not try to, I think as a government official, this is such a difficult topic, to choose one estimate is going to be, challenging, especially at the initial stages. So I think that's I think how we're thinking about it. And so, yeah, we're very excited. Of course, we're very excited to see David's work, and it's great to hear they're working on, the younger population. I've been very happy, to see Marcia's work, and to, she let me join some of that work later on, but I'm really happy that that they're trying to tackle this as well. Anyway, that's it. Thank you.
Great, thank you. And Dr. Weaver, your work with the global burden of disease data, which has the great strength that it's available virtually for every health system on the planet. What is your suggestion to researchers about first steps in applying your methods, particularly on the spending side? Of course, you have that whole DEX study for the US. How would they go about doing that and then using the global burden of disease data to apply your method?
So, okay, so there are countries that are already doing similar DEX studies. We have colleagues in Norway and Switzerland, and I think Australia, who've been doing similar efforts to measure disease expenditure. And other countries are actually maybe sometimes easier than the United States. Like I know Taiwan has really fabulous national health data, and to the extent that they have fewer payers, it might be easier to look at health spending across diseases consistently. I actually think the United States is particularly difficult because we have so many different payers and out-of-pocket spending. So I think countries that have kind of more limited number of payers and more centralized health data might be in a position to do their own disease expenditure studies. And we're already collaborating with a few countries that are doing this work. And then, once you have your expenditure studies and the goal burden of disease, then it's, it's a pretty straightforward calculation.
Excellent. That's exciting. Well, thank you all so much. And thank you all for joining us today. That concludes our webinar.